She received her medical degree from Washington University and went on to complete her residency in hematology oncology fellowship at the Hospital of the University of Pennsylvania, where she's currently an associate professor of medicine. Today she'll be presenting on fertility preservation in transplant patients. Please join me in welcoming Dr. Alison Loren.
Thank you very much. I also want to thank everybody for coming today. I know the beautiful weather is a compelling competing risk, so I'll try to make it worth your while. So I don't need to tell this audience that fertility is a major issue in transplant survivors and is a strong determinant of quality of life. We're getting much better at doing transplants, thankfully, and our patients are living longer, which makes survivorship a key consideration for these patients, and fertility is a major consideration in thinking about quality of life in long-term survivors. More than half of patients who are cancer survivors have reported that if they are infertile due to their treatments, they have increased emotional distress, and the likelihood of being distressed about infertility is much higher in patients who are younger and those who had no children prior to their cancer diagnosis. So today I'm going to tell you a little bit more about the risks of infertility due to chemotherapy and transplant. We'll talk to you a little bit about how to talk to your patients about this issue, and then give you some strategies to talk to your patients about what is an option for them in this particular group that we're seeing immediately pre-transplant. I just want to frame this also with a case. This is a young woman that I saw a few years ago. She was 22 when she came to medical attention with fatigue and pancytopenia. A bone marrow biopsy demonstrated AML, and she had monosomy 7 on her cytogenetics. So this is a young woman. Before we even started treatment, we knew she was going to need a transplant, and therefore her fertility was going to be at risk, and so we had an opportunity to think about that for her before we started therapy. So just a brief overview to help you understand sort of how this issue came about. The observation that gonadal failure occurs with chemotherapy has a long history. The first observations came in the 50s and 60s in women who were receiving oral busulfan for CML and stopped getting their periods. And these observations led to a number of publications in the 70s that made some really seminal observations. First, that alkylating agents and radiation are the key offenders in terms of causing gonadal failure, and that the risks of amenorrhea in women increase at the if the women are older at the time of therapy and with higher doses of treatment. And so there's a huge body of literature on this, but I just want to highlight a couple of more recent studies that have demonstrated decreased chances of becoming pregnant after cancer therapy and after transplant. The childhood cancer survivor study demonstrated that survivors of cancer compared to their siblings were 20% less likely to report a pregnancy, and significant risk factors included exposure to cyclophosphamide as well as radiation to the pelvis. And I just want to highlight that in women who received high doses of radiation, 10 gray or higher, they were 82% less likely than their siblings to report a pregnancy. And looking specifically at bone marrow transplant survivors, women who were survivors of transplant were 36 times more likely than their siblings to report no history of conception. So this is clearly a challenge for our patients. So I just want to tell you a little bit about the biology of the ovaries because I think it's actually instructive. So you may know that oocytes are actually formed in utero. They begin forming in female fetuses at about 15 weeks gestation, and by 20 weeks you actually have the maximum number of oocytes you're ever going to have at about 6 to 7 million. And the process of oocyte depletion and follicular atresia actually begins before birth. I get more and more depressed about this every time I give this talk. And by the time of birth, female infants are already down to just 1 to 2 million oocytes. By age 18, girls are now down to about 100,000 oocytes, and this process of oocyte loss continues until around age 37, about 25,000 oocytes left, and at age 51, which is the average age of menopause in the United States, only about 1,000 oocytes are left. And so menopause basically happens when you run out of oocytes, and that's sort of where this chemotherapy sort of comes into play. So sorry for the big picture of the ovary, but it's actually very helpful to sort of tell you a little bit about how this is all working in real people. So the ovary largely consists of primordial follicles. These are dormant oocytes that are sort of just hanging out, not doing anything. Eventually, they get recruited to mature into primary and then secondary follicles, and those oocytes are nourished by this key layer of granulosa cells that really form a nutritional network that supports the development of the oocytes. Eventually, one oocyte matures to the point where ovulation occurs, and then there's involution of the supportive network. And so when you think about chemotherapy, we all know that chemotherapy works by killing cells that are growing and dividing quickly. So it's sort of relatively clear why chemotherapy is associated with damage to the maturing cells. So chemotherapy has been demonstrated to cause apoptosis or cell death of the granulosa cell layer. So as you kill off the sort of nutritional support of these maturing oocytes, you can understand why there's sort of an immediate loss of menstrual cycles. But what about these guys, these primordial follicles? They're just sort of hanging out. They're kind of quiet. And it's been really mysterious to all of us why it should be the case that chemotherapy should actually deplete these pools as well. A number of theories have been advanced, including the fact that alkylators and radiation have direct toxicity to cells, so you don't need to be dividing to be damaged by those particular agents, particularly alkylators at high doses. There's also evidence that ovarian cortical fibrosis occurs, so sort of scarring of the ovary, which diminishes blood supply to these dormant cells, which can also result in their death. And finally, there's something that's known as the burnout theory, which basically has been shown in vivo. As the maturing cells are dying and the granulosa cells are dying, granulosa cells in normal women elaborate a number of hormones, including anti-Müllerian hormone, that actually inhibit the continued maturation of the primordial cells to basically make it so that only one or a few oocytes actually go into the maturing process at any given time. When these cells are dying, the AMH levels go down, and that inhibitory signal is lost, which recruits more of these dormant follicles into the maturing phase, which then makes them even more susceptible to chemotherapy as their supporting network is damaged. So multiple ways in which the ovarian function is damaged. Radiation is also really bad for your ovaries. This is actually a very interesting modeling study. So the estimate at which 50% of your oocytes are lost, the radiation dose is quite low, less than 2 gray, which I want to remind you is the dose that's given to the non-myeloablative transplant patients. So even reduced intensity probably is damaging to oocytes. These are graphs that demonstrate if this on the x-axis is the age at the time of treatment, and on the y-axis is the projected age of ovarian failure. This graph is a dose of 3 gray, and this graph is a dose of 12 gray. So as an example, if you're 20 when you receive a dose of 3 gray to your ovaries, you can estimate the age of ovarian failure to be around age 35. And for women who are being treated at 12 gray, which is the dose we give for myeloablative transplants, if you're 20 when you receive your 12 gray, your age at ovarian failure is basically 21. So you can sort of imagine that for women who are treated at these 12 gray doses are basically permanently infertile from the time of treatment. I just want to point out this is a very tricky area. So amenorrhea and infertility are not the same thing. I'm sure you all have patients in your practices who have regular menstrual cycles but can't get pregnant. We also have patients who never get a period and then surprise get pregnant. So I like to try to remind my patients that bone marrow transplant is not birth control, and that's a whole other conversation actually. But to remember that there's actually a lot of progress in this field as well to sort of estimate fertility, not based on these traditional methods of estradiol and FSH and whether you get your period, but looking at serum levels of anti-Müllerian hormone is a very reliable predictor, as well as antral follicle counts, which are basically done by transvaginal ultrasound looking at how many viable follicles are in the ovaries. The other thing to remember is that just because you get your periods doesn't mean you have normal fertility. And so this study looked at about 210 women. A third of them were ages 15 to 39 and never had chemotherapy. A third of them were ages 15 to 39 and were treated with chemotherapy. And a third of them were menstruating women age 40 to 52. And you can see this is just one of the measures in the study looking at anti-Müllerian hormone levels, and you can see that the younger untreated women had nice high levels of AMH. The women who were treated with chemotherapy, they were divided into low dose and high dose, and the low dose women had a compromised level of AMH. But the young women, remember these are women 15 to 39 years old who had been treated with chemotherapy at high doses, had the same ovarian reserve as older women who had never received chemo. So this basically brings up the idea of reproductive age, that with chemotherapy you are basically aging your ovaries and probably the rest of your body too, and reminds us to think about what has been termed a fertility window. So basically, even women who regain menstrual function may not go on to develop menopause at age 51, but they probably are going to go into ovarian failure much earlier. So you can't just assume that just because your patient is menstruating, everything's going to be fine. You still need to be counseling them about their reproductive health. This study really demonstrates that well. So this was a look at about 1,000 female patients who were treated for cancer in their late teens. They were all 5-year survivors, and they all were menstruating at age 21. And this study showed that 40% of them were menopausal by the age of 31, and that the risk of going into menopause by age 25 was significantly increased 9-fold if they had been exposed to alkylator therapy, almost 4-fold if they'd been exposed to radiation below the diaphragm, and if they had both, the results were multiplicative, with patients being treated with both agents having a 27-fold increase of being menopausal by the age of 25. Just briefly, so men don't feel left out, I just want to remind you sort of how the male sperm formation works. And I think one of the key differences to remember is that unlike women, who all their oocytes are made before they're born, and that's how many you've got, men are constantly making new sperm. It takes about 75 days to make a new sperm, and they're being made constantly over the course of a man's life. Sperm are made in the seminiferous tubules, which live inside the testis. The early sort of spermatogonial stem or germ cells are at the outside of the tubule, and as the sperm mature, they move their way in until they're basically mature sperm in the center of the tubule. Then they travel out and get stored in the epididymis for later use. And so in terms of thinking about azoospermia, again, alkylators and platinum agents are the most toxic, same as for women, but there's a decline in the rate of sperm counts. So remember, there are a bunch of preformed sperm in there, and they're not going to be affected by chemotherapy. So sperm counts don't actually fall until a couple of months after chemotherapy started. But unlike oocytes, chromosomal damage to these formed sperm still happens. And so really, once there's exposure to chemotherapy, you can assume, even though the sperm counts may not fall, that the sperm are still not healthy to use. The other thing to remember is that there is a chance of spermatogenesis recovery depending on the dose of therapy that's given. If the doses of chemo or radiation are high enough to damage these sort of stem cells, then they're not going to recover. But if it's not high enough, then they can actually recover spermatogenesis. And so, again, radiation, same thing, very bad for sperm. The nadir sperm count typically occurs about 4 to 6 months after treatment is started. Unlike the rest of our bodies, sperm are more sensitive to fractionated radiation, so the typical way that we treat our patients to protect them from other ill effects of radiation is actually more damaging to sperm. And as you can see, with higher doses of radiation, spermatogenesis can recover, but it can take quite a long time, and many men don't ever recover. So I want to remind everybody that ASCO does have a guideline publication about this. It was initially authored by Stephanie Lee in 2006, and we updated it just recently. Basically, I don't think anybody needs to be reminded that high doses of cyclophosphamide, busulfan, TBI have a high chance of permanent amenorrhea. But what I really want to emphasize is that the treatments that most of our patients get before we meet them actually have quite a low chance of permanent amenorrhea. There's nothing out there about how these regimens affect male spermatogenesis, so we're really operating in a very data-free zone. But this is a key point that I want you to remember when we talk a little bit later. So how do we do about talking to our patients about this? Well, our patients really want to hear it. When young patients are diagnosed with cancer, it's been described as a dual crisis of both a cancer diagnosis and a threat to their fertility. Recent studies have shown that referring patients to a fertility specialist significantly decreases regret and increases life satisfaction after their treatments are over. So this study actually looked at women who were counseled just by their oncologist versus those who received fertility counseling. And there were significant improvements in regret scores, distress, and quality of life if they actually met with a fertility counselor, even if they didn't do anything to preserve their fertility. We don't talk about this very much. It turns out, and this has been repeated in a number of different studies in all different ways, that fewer than half of adults who were childbearing age when they were treated for their cancer felt that they received adequate counseling and referrals. There are a number of disparities that have been observed, again, pretty consistently. Men are referred much more often than women. In a recent study, Latino patients were less likely to be referred, and less than half of oncologists, when they were surveyed, actually said that they always or often referred their patients for fertility preservation, even though most of them acknowledged that they were aware that cancer therapies are a threat to fertility. So we were interested in whether bone marrow transplant doctors do a better job, considering the fact that we know we're making all of our patients infertile. And it turns out we're not really much better at that either. So this is a study that I did in association with the CIBMTR, surveying bone marrow transplant physicians about their practices and knowledge base about fertility. And again, about half of transplant physicians actually refer. And when we were trying to understand why, the physicians said that either the patients were too sick to delay transplant, they thought they were already infertile from their prior therapies, or they just didn't have time to talk about it. So I'm going to tell you today why these three things are actually not true and are no excuse, and to tell you that the pediatricians in the room are much better at this than we are, but the most important determinant in terms of likelihood of referring was having access to a fertility specialist. And so one of the things that I want you to take away today is how to build an oncofertility program at your center. There's an organization called Fertile Hope, which is part of the Live Strong organization that provides education and resources to cancer centers about oncofertility. And there's a number of descriptions in the literature. I'll actually refer you to this most recent publication. It's still only available online, that basically gives a blueprint for how to set up a program. And essentially the key components are educational conferences, so in-services, cancer center grand rounds, basically raising awareness, raising education. Instituting reminders like prompts in the electronic medical record, or adding a specific fertility section to the consent form so that patients are reminded to ask their physicians about it and physicians are reminded to talk to their patients about it. Developing educational materials for patients, brochures that are prominently displayed in the waiting room for patients to take, websites or links, and then providing easy access to fertility specialists. So reaching out to your gynecology colleagues, understanding, and your urology colleagues, understanding who's out there, who are your resources, how can you get them in. I can assure you that our colleagues in those specialties are very interested in these patients and want to see them and are frustrated that we're not sending them. And I think if you reach out, you'll find that they're very interested in making themselves available for rapid consultation. They know that these patients can't wait 4 weeks to be seen. And so whether there's a specific email or a dedicated hotline or a patient navigator, basically somebody to sort of smooth over the bumps and make sure that the patients can get in. And in two publications that described the rates of fertility referrals before and after such types of programs were implemented, you can see a significant improvement in the number of men who actually sperm banked, and in another center, just providing brochures in the waiting room and a hotline that basically connected them directly to somebody who could give them a prompt appointment resulted in a 9-fold increase in fertility referrals. They had 13 phone calls the year before they implemented this program and 122 the year after. So what are the options for our patients? And I'm going to try to give you this information very briefly, again, to try to address the issue of no time, just to sort of give you a sense of what's out there. So I'm going to focus on non-anatomic approaches because most of our diseases are systemic therapies, and for women, the two standard options are embryo banking and egg banking. And basically the procedures that the women receive hormone therapy to stimulate egg production. The goal is to stimulate multiple eggs to sort of mature all at once. They are then retrieved through a minimally invasive surgical procedure that's done under anesthesia. It's a transvaginal needle aspiration to retrieve the oocytes. And then if you're going to freeze an embryo, those oocytes are fertilized by sperm. If you're not going to freeze an embryo, you can actually just freeze the egg by itself. Then there's no fertilization step, obviously. The products, either the oocytes or the embryos, are then removed, they're frozen, and then later when the woman's ready to conceive, they are reimplanted back into the uterus. For embryo cryopreservation, this ovarian stimulation process, when you're using typical protocols, can result in high estrogen levels that tends to be frowned upon in women with hormone receptor positive cancers like breast cancer. But again, for your information, just to know, there are other protocols that are now well established using tamoxifen and letrozole that significantly lower the estrogen exposure for women and have been safe and effective in both breast cancer and other patients. There was, in the older days, it used to be that you had to wait for the right point in the woman's menstrual cycle in order to start the hormone therapy, and then it took, several weeks to get them up and running. So it could take as long as 4 to 6 weeks to prepare a woman for oocyte harvest. This is no longer the case. So the issue of too ill to delay transplant, I don't know if you're practicing in miraculous transplant centers that can get a patient to transplant in 14 days. I know I'm not. And so however long it takes you to get them to transplant, I think you have 2 to 3 weeks while you're getting them ready to send them to a fertility expert. These rapid induction protocols are very effective and very safe. It sometimes comes up whether there's a concern for an increased risk of venous thrombosis given these high sort of hormone stimulation protocols in women with active cancer. Nobody has studied this. There's nothing out there in the literature about it at all. The other thing about embryo preservation, cryopreservation, obviously, is that it requires a male donor, and so the patient either has to have a male partner or be willing to use donor sperm. Preserving the oocyte alone was a technical challenge for a long time. It turns out the oocyte is a very large, complex single cell that's quite fragile, and so the process of freezing and thawing it was very challenging for a long time. But fortunately, our reproductive endocrinology colleagues have gotten to the point where they're very good at this. The American Society of Reproductive Medicine in 2012 declared oocyte cryopreservation no longer investigational. So this is sort of has the same, as I mentioned, the same process for harvesting the eggs, but then the eggs themselves are frozen. So this is a great option for women who are post-pubertal but don't have a partner, don't want to use donor sperm, or may have ethical concerns about freezing an embryo. And so you can see really that the time course is really quite reasonable for these women. They can be seen and started on ovarian stimulation protocols, retrieve the eggs within 10 to 14 days, and start cancer therapy immediately following the harvesting procedure. There are some experimental methods that I just want to touch on briefly because you'll probably hear about them. These include ovarian suppression and ovarian tissue banking. This is an extremely controversial topic, the question of using GnRH analogs, either agonists or antagonists, to preserve fertility. There have been a number of studies published on this. Basically, they all show either no difference or a slight advantage to using GnRH analogs to protect menstrual function and ovulation, but in a large meta-analysis, there was no difference able to be demonstrated in terms of pregnancy rates or antral follicle counts. Until this year's ASCO. This was a very important study, late-breaking abstract at ASCO this year, about a 300-patient prospective randomized trial of women with early breast cancer, randomized to receive a GnRH antagonist or not. And the women who received the GnRH antagonist were much less likely to be amenorrheic at the completion of therapy, and for the first time were able to show an increased chance of achieving a pregnancy compared to their untreated controls. So this is a long story that to be continued, very controversial. I will mention that for patients with acute leukemia, Burkitt lymphoma, things that really can't wait, can't wait 10 days, can't wait 1 day, this is something you can do for them. It may work, it may not. They need to understand that they can't count on this, but at least it's an option that's out there that's relatively safe. Ovarian tissue banking is a very exciting, up-and-coming, research-based option. This is great. Basically, what happens is there's a small abdominal incision. Either the ovary entirely is removed or portions of it are removed, and then cortical strips are frozen. This is a great option because it can be done immediately. There's no hormonal stimulation that's required. This is really the only option that's available for pre-pubertal girls, but it really remains investigational largely for the concern of reintroduction of cancer cells. This has actually occurred in mouse models. It's never occurred in humans, and I'd be happy to answer questions about this, but really for now I think the jury is out in terms of the risk for heme malignancy patients. For men, it's all about sperm banking, and unfortunately for the transplanters, really the optimal situation is for them to have collected before they've seen chemotherapy. Questions about how long do they have to be post-chemotherapy, like how long does the chromosomal damage last, and what if they're 3 months, what if it's been 6 months, when is it safe to consider sperm banking, all of this, again, there's no data, nobody knows the answer to those questions. So in terms of, thinking about situations where you're seeing a patient after they've been treated but before they've been transplanted, what can be done? There's an emerging body of literature that's really case series but pretty compelling that women at least can be successfully, oocytes can be successfully retrieved even though they might have received prior chemotherapy. So this was a 2-patient case series looking at 2 young women who had received GnRH agonists during their induction. So again, controversial, but an attempt to preserve fertility. and then were able to have oocytes successfully retrieved after their chemotherapy before they went to transplant. And then in another larger study from our institution, a subset of 14 of the patients described in the paper were post-chemotherapy patients, and 11 of them were able to successfully retrieve oocytes even though they had been treated previously. The questions about whether the oocytes are safe, whether there's genetic damage, again, nobody knows. Patients have to be counseled, but at least it's an option. And even for men, so men with cancer, even before they get treated, it's not uncommon for them to have low sperm counts. I still encourage them to bank because there are methods like intracytoplasmic sperm injection where you really only need one viable sperm to fertilize an egg. And there are also techniques to extract sperm in men with low sperm counts after therapy. So to get back to my patient, I met her on October 13th. She actually lived quite a distance from our center, so even though our fertility expert was very happy to see her as soon as possible, she didn't want to come back for about a week. Once she saw my colleague, she was successfully able to undergo oocyte retrieval, and 3 weeks later she had her eggs frozen. She received chemotherapy induction with standard 7 and 3, and then a Cy TBI allo transplant. What's really particularly interesting about her is that she also gave us a distant history of lymphedema, and one of my very astute colleagues thought that she may have Emberger syndrome. This is a constellation of symptoms, constellation of illnesses including AML with monosomy 7 and lymphedema related to a deletion of a gene called GATA2. So it turned out she had this, which was unexpected. Her parents were tested and they were not carriers, so this was a new mutation for her. She's now 4 years post-transplant doing very well. But the reason I bring this up is that this has enabled us, because she has banked embryos, to potentially consider pre-implantation genetic diagnostics so that she can be reimplanted with unaffected embryos. So just some takeaway points. Please remember to talk about this with your patients. They want to hear about it and they want to know. Please encourage your patients to explore all their options. Even if they seem like they're not interested, they should still go and talk to people so that they have a sense later that they've done everything that they can. Remember that for women, there still may be options to preserve their fertility even if they've had chemotherapy. And remember that even if there's nothing to do to preserve their fertility, there are still ways to build a family. There's adoption, there are donor egg programs so they can still carry a pregnancy even if they don't use their own eggs. So really the bottom line is it's not your job to go into all the details with these patients, just remember to refer them to your fertility specialist. And here are a bunch of resources that are really, really helpful. There's an Oncofertility Consortium that can help connect you with experts. Find a fertility specialist's hotline will connect you with an available oncofertility specialist in real time, and I forget which of these has an app that you can actually download that can calculate your patient's chances of infertility. Thanks so much for your attention. I don't know if I have time for questions. I think I have like 42 seconds for questions. Yes? Yes, so there is, I'm not sure I would call it data, but there's definitely reports. I think what you're getting at is there an increased risk of congenital anomalies, and so there does not appear to be. Certainly women who become pregnant post-transplant are high-risk pregnancies. They should be referred to an MFM specialist, maternal fetal medicine, for cardiovascular reserve assessment, pulmonary reserve assessment. There are issues in women who have received TBI that the uterus is fibrotic and can't expand. So they're definitely at increased risk for preterm birth, low birth weight, but the actual risk of congenital anomalies does not seem to be higher in cancer survivors compared to the general population.
Excellent. One question more than comment. What your experience been in terms of getting insurance approval for the procedure? Because that's one of the things.
Right. So there's actually a big movement for this, and I think California has successfully lobbied the state to mandate this. So really, I would encourage you to think about this as, or help your colleagues think about this as a complication of chemotherapy, just like hair loss, right? How many of you have written a prescription for a cranial prosthesis so they can get their wigs covered, but they won't cover this? They'll cover breast reconstruction after mastectomy, but they won't cover this. This is a complication of cancer therapy just like any other. And so I would say that I have not encountered a lot of difficulties getting insurance companies to cover this. I know in Canada it's a very different story. I have no idea what it's like in Europe to get this covered. But I have found that there's a lot of charitable organizations. Some of these consortia and organizations will actually provide funding. It's not unusual for the pharmaceutical companies to donate the drugs that are needed for the hormone stimulation. So you just have to be creative and have a really good social worker. All right, thank you.